you see it looks like a kidney bean. You know, it's kind of got its concavity. Okay. As discs degenerate, they may get a disc protrusion and become a little more flat, and that would then cause maybe mild stenosis, which we'll talk more about. Okay. So we assess the disc. The second thing that we will do is assess 4 specific nerve roots. Whoops. Okay. 1, the exiting nerve root on the right. So L3-4, this would be, Kyle?
L3.
L3, okay, very good. Left L3, right? And then in the lateral recess, Mike, it would be
4.
4.
The traversing nerve root.
It is right. The traversing nerve root would be 4. Okay. So even as I express to patients, I want to see 4 nerve roots, 2 exiting and 2 in the lateral recess. And I'll even illustrate to them, and I'll say, like, just to give you an idea, there's 2 exiting nerve roots, there's 2 forming, 2 exiting, 2 forming, all the way down the spine. Okay. And so when you go through your analysis, look for those 4 nerve roots. Okay. And as you can see here, there's really nothing touching on them, pushing them out of place, or smashing them, or whatever. Okay, so these are all good looking. Okay. Let me look at that, or that, or that, or that. Okay. Now, when we're assessing the axial view, there are different zones that we do need to mentally walk through. Okay. Obviously, the central canal is the easiest. We're just looking at the center. Okay. Off to the center will be the lateral recess. In our practice, we call it the gutter. That's how we actually refer to it, the lateral gutter, okay, lateral recess. And then the foramen, or the pathway for which the nerve exits the spine, okay? Now, on the parasagittal cut on an MRI, we can also see foraminal views, and that is somewhat helpful. And we'll talk about how to interpret those things. Now, I guess this is talking about like radiologists going to look through all these things and what have you, and they're supposed to assess all these different things, not that they always do. But this is the most important thing here is you must also be able to interpret and grade things, because you are the one doing the procedure. And I can assure you that if something happens and you say, well, I just looked at the report, you will write a check, okay? Okay. So my point being is you're the one working on the patient. They're your patient. You need to know what you're approaching. I did a medical review about a month ago, and this doctor did a cervical epidural at a level of the neck where there was cervical spinal stenosis. So you don't get the loss, and then he proceeded to inject. It's either 5 or 10, but I think it was 5 or 10 cc's into the cord.